The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. This is Erin Rachmiel here, and I am representing MASEC, the Missouri Antimicrobial Stewardship Education Collaborative, and today we're going to be doing a webinar on vancomycin dosing. We're going to be talking about the literature that supports or the recommendations for our current practice for monitoring vancomycin, as well as a review of the current literature and some practical considerations. And let me see if I can get this slide to go forward. There we go. I have no disclosures to make. I'm going to make a plug here for our mo.stewardship@wustl.edu email, which is our MASEC email. That is a central point of contact for us. A reminder that it's not for urgent or emergent clinical questions. We're not a consult service, but we love to hear from you guys. And you know, if you have questions about approaches to difficult cases or challenges that you're facing, if you need help finding resources, if you are looking for, you know, someone to talk to about your stewardship issues, we love to hear from you guys. We like it when you send us cases that we can discuss in our case conferences. And also want to mention that we are offering one-on-one stewardship consultation. So this would be a phone call with me where we get to chat about your stewardship program, and you know, we get to learn about what you're doing and what challenges and barriers you're facing and hear your success stories, and then hopefully you would get some tips or some information from us that might help you as you move forward in your stewardship efforts. I'll also mention at this point that I have Dr. Kevin Schway on the phone with me, as well as Dr. Michael Durkin, who hopefully will chime in and speak up as there are things that they want to add to our conversation today as well. And you all have the opportunity to raise your hands using the GoToWebinar software. If you have any questions, you can write them in or raise your hands, and hopefully we can get those questions answered. This is an interactive session, so like we do in most of our presentations, we're going to ask you to log in to Poll Everywhere. So if you could take a minute to do that now, I'll give you guys a second to log in and let us know that it's working and that you're on the line with us.
This is Dr. Choi. I will also be monitoring any of the GoToWebinar raised hands, and the moment that you raise your hand, I'm going to try to unmute your line so you can ask any questions of Erin or the rest of us. So I'll be watching.
Thank you. Looks like we've got a couple people that have logged in. There are a few polling questions throughout the webinar, so once you log in to Poll Everywhere, you know, just keep that screen open so that you'll be able to respond to us and we can get a little feedback from those who are listening. That's always helpful. Okay, we've got 4 of you that have logged in. Hopefully the rest of you will get logged into pollev.com/MASEC. So I'm going to start just by talking about vancomycin, just to get everybody on the same page and thinking about the topic here, some vancomycin basics. Most of you know all of this information, but just to bring it to the forefront, vancomycin, as you know, is a glycopeptide antibiotic. It is active against gram-positive organisms, used for gram-positive infections. It's been in clinical use for about 60 years. And as you know, because most of you practice in hospitals, it is a commonly used antibiotic in the United States, especially among our hospital patients. So it's something that we use all the time. The early use was associated with ototoxicity, nephrotoxicity, and infusion-related reactions. A lot of that early toxicity was thought to be related to impurities. The process was refined, and the drug no longer has those same impurities that were present when it was initially used. And a lot of the toxicity that we saw did decrease. However, we're going to talk a lot about nephrotoxicity today. And so, you know, that's still an issue with vancomycin. And as you probably know, infusion-related reactions are still an issue, but can often be controlled with just extending your rate of infusion. So it's something that we watch for, but we usually can manage those reactions. With the availability of the semi-synthetic penicillins, we kind of saw a decreased use of vancomycin for a while, but around the 80s, and since then, with the prevalence of MRSA, we have seen increased use of vancomycin. So, as you know, again, it's something that we use all the time. This is just a kind of a generic slide to go over some of the vancomycin kinetics and remind everybody that it does have a biphasic curve here. So we have the alpha distribution phase. When you infuse your vancomycin, you want to be careful. This is really important when we're talking about drawing levels, because if you draw your level too soon after the end of the infusion, you're going to be drawing a level within this alpha distribution phase, which lasts about 30 minutes to 1 hour, and that's going to give you an artificially high peak. So when you're drawing your first levels, you want to wait until after that distribution phase has passed before you draw your levels, because this will give you an artificially high level. So that alpha distribution phase lasts about 30 minutes to an hour, and then you have the beta elimination phase. Half-life is usually 6 to 12 hours. Is cleared renally, so that is dependent on your patient's renal function. The volume of distribution is listed there, as well as noting that the drug is pretty highly protein bound, about 50% protein bound. And it is it is a concentration independent killer, which basically means that we're not so much concerned about the Cmax, or the maximum concentration of vancomycin, when we're thinking about its effectiveness. So this slide is just a slide that will remind us of all the pharmacokinetic and pharmacodynamic parameters that we think about when we talk about antibiotics. And so, this is your standard time versus concentration curve for an antibiotic, and some of the pharmacokinetic parameters that we look at are the Cmax, or the peak level. Some antibiotics, as you know, the Cmax is really important and is really closely associated with efficacy, especially as you compare it to the minimum inhibitory concentration, which is represented by this dashed line down here, of the organism that you're trying to treat or trying to kill. So for those antibiotics, looking at the peak concentration and comparing that to the minimum inhibitory concentration, and having a big difference there, or a large ratio of your Cmax over your MIC, is important for concentration-dependent killers like aminoglycosides and fluoroquinolones. We also have antibiotics that are known as sort of time-dependent killers, where the time that they're above the MIC, the time that they're higher than this dashed line here, that their concentrations are higher there, is really important. And so, we classically think of our beta-lactams as being time-dependent killers, where the peak isn't so important, but just keeping them above that MIC for as long as possible is really important. And then the parameter, the pharmacodynamic parameter, that's a little bit more difficult to measure and involves more calculations is the AUC, or the area under the curve, which is this whole, oops, I did not mean to go forward yet, this whole gray area underneath the curve. And so if you remember your pharmacokinetic classes, this can be calculated by some fairly sophisticated calculations. And usually you need to have at least 2 drug levels somewhere along this curve, and then you can do a calculation and figure out what your area under the curve is. And so one of the parameters we're going to be talking a lot about today is the area under the curve as it compares to, or as it relates to, the MIC. So the ratio of AUC to MIC, and how that is associated with the efficacy and the toxicity of vancomycin is really what we're going to be talking about today. So I just wanted to get a little bit of audience feedback here and find out if there are any hospitals that are currently using AUC-guided vancomycin dosing. And so you can just say, yes, we are, or we're in the process of making the change. We've talked about it, or we haven't talked about it. I was surprised when I did the literature search and was getting ready for this presentation at how many publications were out there from hospitals that have made this switch. Obviously, relative to the whole number of hospitals in the United States, it's not that large of a number, but it was more than I expected. There are definitely pockets of areas in the United States where there's a lot of research going on in this area, and hospitals in those areas are doing it. But I was surprised to find that there are areas across the country, and more than I thought, that were interested or already doing AUC-guided vancomycin dosing. So it looks like we've got a fair number of hospitals that have talked about it, and also some that have not talked about it yet, which is about what I expected to see. So we've got 73% that have talked about it. That's good. So people are aware of the issues. So I thought I would start with the guidelines that were published for vancomycin therapeutic drug monitoring. These were the first and so far only guidelines that have been published for vancomycin monitoring. They were published in 2009, and it was a joint effort between the Society of Infectious Disease Pharmacists and the American Society of Health System Pharmacists and the IDSA. And so sort of the high-level summary of their recommendations back in 2009, they noted in their guidelines that the AUC to MIC ratio was the preferred monitoring parameter. And I'm going to come back to that with our next slide. But even though they noted that the AUC to MIC ratio was the preferred monitoring parameter, they didn't recommend that we actually monitor that. They recommended that we monitor trough levels. And they noted that they called that the optimal monitoring parameter. And that was a level 2B recommendation, which means that that was based on either non-randomized trials or cohort or case-controlled trials, and there was moderate evidence to support that at the time. The guidelines state that monitoring the trough was more accurate and practical. You know, the AUC, in order to monitor the AUC, you need to draw multiple levels within one dosing interval, and it was more complicated. So it felt like, or they felt like, the experts felt like that monitoring just a single level, the trough, was a more practical way to monitor the drug. Their recommendations for our targets at that time were that we keep the troughs greater than 10 milligrams per liter to avoid the development of resistance. And for most infections, they recommended a target trough of greater than 15. And the idea there was to attain an AUC to MIC ratio of 400. It's important to note that they state in the guidelines that you would attain that target AUC to MIC ratio with a trough of 15, assuming that your minimum inhibitory concentration was 1. And it's important to note that the laboratory guidelines, the cutoff for sensitivity is 2 milligrams per liter for your MIC. So this ability to attain your target AUC to MIC ratio with a trough of greater than 15 assumes an MIC of 1. So you still have some percentage of your infections where the MIC may be between 1 and 2. And since you're not monitoring AUC to MIC, you don't really know if you're reaching that target with a trough of 15. Kind of for that reason, they recommended for serious infections, for complicated infections, that you could even push the trough to 15 to 20 milligrams per liter. They also note in the guidelines that at the time, there was not a lot of data to support the safety of doing that. There wasn't anything to say that it was unsafe, but there was also not a lot of experience in treating patients for extended periods of time with trough levels that were up in the 15 to 20 range. It's also important to note that they did not recommend that we monitor peak levels because they had not been correlated with efficacy or toxicity. So those are the guidelines in 2009. The AUC to MIC recommendation that they made, noting that it was the preferred monitoring parameter, was based on animal models, in vitro studies, and limited human data. They noted that an AUC to MIC ratio of greater than or equal to 400 was a target to achieve clinical effectiveness, and that to achieve a successful microbiological outcome, you may need even a higher AUC to MIC ratio. Also important to note, and this is stated in the guidelines as well, that with what was sort of the standard dose at the time of a gram Q12 that you would give most patients, that you were only likely to achieve an AUC of 250 in sort of your average patient. So and I don't even know if that's, you would really say an average patient, because most of our patients in the hospital are not necessarily an ideal body weight and don't have great renal function. But in a patient with an actual body weight of about 80 kilograms and good creatinine clearance, with the gram Q12 dosing that was kind of the standard at the time, you're likely only to get an AUC of 250. So if your target AUC to MIC ratio is 400, you would probably need higher doses to achieve your target AUC to MIC ratio. So, the result of that guideline was basically us pushing for higher troughs and giving higher doses of vancomycin. So what have we learned since then, and what concerns have emerged about trough monitoring? There was a paper published by Pai in 2014, and he's one of the researchers from Detroit, which you'll see a lot of data coming out of that research group in Detroit. But that paper in Pai was, or in 2014 by Pai and colleagues, was a review of innovative approaches to vancomycin delivery. So they were looking at different ways that you could target the AUC to MIC ratio, and also evaluating some of the data that have been published to date. And they noted that there were several studies that demonstrated no link between efficacy and targeted trough concentrations, which is a problem because, our guidelines were recommending that the trough concentrations was what we monitor. So it's concerning that there is really not much data to support a link between efficacy and targeted trough concentrations. Another review paper that was published by Van Hal and colleagues in 2013 was a meta-analysis. It had been noted that since the guidelines were published in 2009, there were more and more case reports being reported of nephrotoxicity associated with vancomycin. So Van Hal and colleagues performed a meta-analysis of available literature, and what they determined through their work was that a trough of greater than 15 is associated with an increased risk of nephrotoxicity, and the odds ratio was statistically significant, and an odds ratio of 2.74. They also noted that when your initial trough, after your first dose, was greater than 15, your odds ratio for having nephrotoxicity was greater than 3. So here we have guidelines that are recommending that our troughs be above 15, but now we're getting more and more data saying that troughs greater than 15 increase our risk of nephrotoxicity, and there's not a link between efficacy and those vancomycin troughs. So you're starting to see in the literature more and more concern about the way we're monitoring vancomycin. So I thought I would stop here and see, hear from the audience. How often do you guys see patients that are failing vancomycin even though they've had appropriate troughs? Is that something that you're seeing in clinical practice? So sometimes. Give you guys a minute to respond. So Kevin or Mike, while you're on the line and the audience is responding, do you guys see patients that are failing vancomycin therapy even though their troughs seem appropriate?
Well, we're infectious disease physicians, so I think our perspective is somewhat skewed. But yeah, I think we would fall into the sometimes category along with, it looks like the majority of others. Most of the time when we see vancomycin appearing to fail, people who remain bacteremic or remain septic despite, a decent time, a period of time on appropriate vancomycin dosing, and with appropriate troughs. Most of the time, that's source control. There's a severely infected source like a valve or a joint that hasn't been properly drained or taken care of. But there are a good number of patients I think we see pretty frequently where just for one reason or another, despite a trough between 15 and 20, the vancomycin doesn't seem to be effective, even though we can't find a source that needs to be managed. So yeah, I think we see it a pretty decent amount of time, and in most of those cases we initially try to sort of just bump up the vancomycin dose, but if that doesn't work, we often resort to more expensive and sometimes more toxic drugs like linezolid or daptomycin. Um, and which, by the way, is not evidence-based really in any way. It's just clearly the vancomycin's not working, so we try something else. There's no real evidence that daptomycin is somehow superior in many of these cases. There are some small studies that show that it may be superior in certain types of severe infections, but we don't know if that really can be um, applied to all situations like this.
This is Mike. I'd be wary about using daptomycin regularly in settings where you're worried about vancomycin failure, because people can develop daptomycin resistance pretty easily in settings where they have inadequate source control. So I've personally seen patients have really adverse outcomes where their isolate was initially daptomycin susceptible and then will become non-susceptible over a period of a week or two on therapy, where people have the perception that daptomycin is a better antibiotic. I agree with Kevin that usually it's a source control issue. We haven't personally seen a lot of issues with MIC creep, or the concept that vancomycin MICs are getting a lot higher, like closer to 2. Most of ours are still 1 or under. The last time I reviewed them. So the concept of vancomycin resistant Staph aureus or something along those lines, although theoretical, it shouldn't be something that's routinely discussed in practice. And if you have physicians that are telling you that, I think it would be reasonable to have some pushback, or say, why don't we talk to the microbiology lab to see if we can calculate what their figure out what the MIC is for this organism.
Yeah, people should remember that some of the mechanisms for vancomycin resistance, or I guess vancomycin intermediacy more than anything else, are the same mechanisms that actually can lead to daptomycin resistance. So yeah, it's thickening of the bacterial cell wall. So there is, they can go in parallel, basically, vancomycin intermediacy and daptomycin resistance. And also remember that the E-test is known to edge closer to overreading the MIC than it is underreading. So oftentimes it'll look like an MIC of 1.5 or so, even when by more gold standard testing, it's probably a little bit lower, 1 or so, just because of the mechanism of that test. Sorry, Erin, we sort of jumped on top of that.
No. No, that's perfect. Great discussion. I like that you pointed out the source control as being an important issue when you're talking about patients that have failed therapy. Okay, so what do troughs really tell us is kind of the question, and is the trough alone a good surrogate for an AUC to MIC ratio, which is what our guidelines had recommended? So again, going back to that paper from Pai and colleagues in 2014, they noted that a trough of 15 to 20 will ensure that you reach your goal AUC to MIC of greater than 400 about 90% of the time if your MIC is less than or equal to 1. So, if the majority of your isolates do have an MIC less than or equal to 1, then you have a greater than 90% chance of reaching your AUC to MIC goal with a trough of 15 to 20. But it is important to note that the laboratory guidelines and the FDA susceptibility breakpoint for vancomycin sensitivity for Staph aureus is an MIC of less than 2. And as Kevin alluded to, the way you test for that does make a bit of a difference. Your E-test is going to kind of generally report a little bit higher MIC than sort of the gold standard of the broth microdilution. So another key or important point is a point about interpatient variability, and this was highlighted in a paper by Neely and colleagues. And Neely is another name, and he's from another group that you will see a lot of information if you're researching this topic. You'll see a lot from his group, which is a group in California. So Neely and colleagues reported in 2014 that in ideal populations, so your your adults that are of normal weight and normal renal function, the AUC can vary by up to about 30%. They also noted that trough concentrations on average underestimate the AUC by about 25%. And interestingly, if you have a trough over 20, somewhere between a quarter and a half of your patients will have an AUC over 700. But if you have a trough of less than 15, and again, that's under what our typical target is, half of your patients will have an AUC of greater than or equal to 400. So in those cases, you would be looking at the trough and probably increasing your dose because your trough is not at your target of greater than 15, but in half of your patients, you've actually already achieved your AUC to MIC ratio, assuming your MIC is less than or equal to 1. But you wouldn't know that because you're not actually monitoring the AUC. So you may be increasing the dose and increasing the risk of nephrotoxicity in patients unnecessarily if you're monitoring the trough level. But the key here is that there's a lot of interpatient variability. So it's hard to know just by monitoring that single point estimate of the trough whether you're really achieving the AUC to MIC ratio that is recommended. So given that knowledge and information that there's a lot of interpatient variability, there's a lot of studies that have been seeking to evaluate targeting the AUC to MIC ratio. And so when you're thinking about your targets for antibiotic therapy, you sort of have to think of two pieces. You think of your efficacy and you think of safety. So sort of looking at the literature that's available for targeting the AUC to MIC ratio as it relates to efficacy, there are several studies that have been published that correlate AUC to MIC ratios and efficacy outcomes. There are some in animal models, in vitro data, and there is some human data, and there's becoming more and more human data available. Some of the early human data was published in 2004 by Moyse and colleagues, and that data was actually referenced in the early guidelines that were published in 2009. So in that study, they evaluated patients that had MRSA pneumonia, and they noted that for patients that achieved an AUC to MIC ratio of over 400, that there were improved microbiologic outcomes. And so that's sort of what guided that recommendation in the guidelines, that if you achieve an AUC to MIC ratio of over 400, that may be the preferred target. Since then, we've had more data published between 2011 up to 2018. A lot of this data that is sort of included here in my summary is from 2011 through 2016. Many of the papers that have been published evaluate patients that have MRSA bloodstream infections and pneumonia. There are a few patients with endocarditis that have been evaluated and with osteomyelitis. And then the most recent paper from 2018 evaluated patients with enterococcal bloodstream infections. The different papers that are published have varying methods for their MIC testing. Some used broth microdilution and some used E-test. It's important to know that when you're trying to compare studies because, as we mentioned, the E-test will tend to report higher MICs. The papers that have been published also report varying methods for their AUC determination. Some of the earlier studies relied more on formulas and calculations, and some of the more recent studies used Bayesian methods. And I will talk quite a bit more about Bayesian methods as we go forward. And so there's a range in the breakpoints that were identified in the different studies where they were associating AUC to MIC ratios and efficacy. And that range went from about an AUC to MIC ratio of 211 up to about 600. But a lot of them had AUC to MIC ratio somewhere around the 350 to 400 range was the level where they saw improved efficacy. And there was actually a meta-analysis that was performed sort of summarizing all of that data that was available in 2016, and this meta-analysis was performed by Min and colleagues, where they concluded that based on the data available, an AUC to MIC ratio of greater than 400 seemed like a reasonable target for efficacy outcomes. So if you're trying to evaluate toxicity, there are also several studies that are published. These are observational studies that were designed to evaluate AUC correlation with nephrotoxicity, and these were a little more recently. Most of them were published between 2009 and 2018. The majority of these papers are evaluating adult patients, and they all defined acute kidney injury the same way, or use similar definitions of an increased serum creatinine of 0.5 milligrams per deciliter, or a 50% increase over the patient's baseline. Most of the evaluations that are looking at toxicity evaluated patients with MRSA pneumonia and bloodstream infections. The majority of these papers used Bayesian software to calculate their AUC. And again, with the results of all the papers that were published, there's a range that's reported. Some of the patients, or some of the papers, found that an AUC to MIC ratio of 560 was associated with an increased incidence of acute kidney injury, and one of the papers even went up to a level of AUC to MIC ratio of 1,300. So there's a pretty wide range there. The largest study was a study, or the largest study in adults was a study published by Zasowski in 2017 that included 323 patients. And they noted that for patients that had an AUC over 700, the risk of nephrotoxicity increased by almost 4 times. I'll mention here, too, that when you're looking at toxicity, you are not so much looking at the AUC to MIC ratio as you are just looking at the MIC, or I'm sorry, looking at the AUC, the area under the curve, because the toxicity is more associated with just the total drug exposure, so the area under the curve that the patient has experienced, whereas with efficacy, you are looking at the drug exposure as it relates to the MIC of the drug, of the bug. And that's important because if you are looking at an organism where the MIC is closer to 2, the total concentration that the drug that the patient is exposed to is going to be twice the amount that you would want to expose them to if their MIC was 1. So just when you're looking at toxicity, focusing on the amount of drug exposure, or the AUC, is really what is important. There was a meta-analysis performed in 2000, and it was published in 2019, that sort of evaluated the data available to date as it relates to toxicity. And this was actually presented in a poster format at ID Week last fall, and then it was published in one of the ID journals in 2019. And they noted that based on the available information to date, an AUC of greater than 650 seemed to increase the risk for nephrotoxicity. It is important to note that nephrotoxicity occurs along a continuum, and you can't really use any particular value to predict who's going to have nephrotoxicity, but as the AUC gets higher and as it increases above 650, was what the results of the meta-analysis said, your patients are going to be at higher risk for developing nephrotoxicity. But there's a lot of other risk factors that can increase their risk as well. So the duration of therapy is important. Patients that are obese tend to have a higher risk for developing nephrotoxicity on vancomycin. If they're on other agents that also increase their risk for nephrotoxicity, and the severity of illness is important. So while we can use these AUC numbers as a guide to help us see who's at higher risk for developing nephrotoxicity, we have to recognize that we can't predict it, and we do have to consider all the other risk factors that the patient may have as well. So here's a chance for you guys to give us a little feedback. How often do you see patients develop nephrotoxicity on vancomycin, despite the fact that they do not have supertherapeutic troughs? give you guys a chance to respond.
And Erin, I'm going to chime in once again from the ID provider's perspective. Yeah, it's pretty. I would say actually, recently it seems like it's more sometimes. I wish it were rarely, but honestly, we've seen quite a bit of nephrotoxicity from our vancomycin. I'm not sure if that is just our patient population. We cater to a number of patients with very significant comorbidities who have all those risk factors you just listed. They're very obese, they are elderly, they often have other exposures to nephrotoxins. Oftentimes they're septic, but um, uh, honestly, it's made it so that we sort of have to intentionally make sure that we don't just resort to other drugs just because we're shy of vancomycin. Yeah, I mean it's a significant problem that we see pretty frequently at this point, and almost certainly due to that increased baseline threshold, now 15 to 20, as opposed to previously it was essentially 10 to 20, often 10 to 15.
Mm-hmm. Okay. And it looks like our audience is telling us that 44% sometimes see it and 56% say they rarely see it. I will say in the literature too, what I saw in terms of rates, it was looking like from a lot of the available literature, somewhere around 6 to 8% of patients with the current recommended troughs were experiencing nephrotoxicity. And again, that is really going to depend on your patient population and the risk factors that they have and how high you're pushing those troughs. If you're getting them up closer to 20 or if you're closer to 15, that all makes a difference. So in sort of summary of what we've just reviewed with the literature, the efficacy data that's available is really based on AUC to MIC target attainment. There's not much data to really associate troughs with efficacy. But the data for the AUC to MIC target suggests that a target of 400 to 600, and again, a target over 400 will sort of help you reach your efficacy goals, but you'd want to stay under about 600 or 650 because above that we know that you're increasing your risk of nephrotoxicity pretty significantly. The other thing is that we also know that there's significant interpatient variability. So it's really hard to know. If you look at this graph, which sort of represents the concentration over time in a patient that was receiving vancomycin, if you're just measuring a trough, it's hard to know which curve are they going to follow. What's their AUC going to be, and can you really predict an AUC based on just a single point estimate of a trough? And it turns out that there's some significant variability, and it's kind of hard to do that. And so the risk is that you may be underdosing some patients, or you may be unnecessarily increasing the risk of toxicity in some patients if you're just measuring the trough. So that's the concern. So given that information, and this idea that the AUC to MIC ratio is probably the preferred target, why haven't we been monitoring that? And historically, calculating the AUC would be really a manual calculation, and you'd need multiple pharmacokinetic samples drawn during the same dosing interval. It really depends on accurate documentation of timing, both the timing of the administration of the drug as well as accurate timing of the lab draws, because you'd be looking for a peak and a trough, and you need to make sure that your peak is drawn appropriately so that you're not drawing it during that alpha distribution phase, and that your troughs are drawn and the timing is documented appropriately, and then you have to do the calculation. So it was just felt to be a really cumbersome process and something that had so many steps and was really ripe for error that was why people used trough as a surrogate for the AUC. However, more recently, we've got technology that can kind of help us, and I think more people are using electronic documentation of drug administration, so we know that our our timing of our drug administration is maybe more accurate than it used to be, which will help us draw our labs, draw our levels more accurately. So between advancements in technology on that end, as well as technology to help us with our calculations, we've got some new options. There's the Bayesian method, which we'll talk about, requires some more complicated statistical calculations and does require software and is an investment, both in terms of financially in most cases, as well as education and implementation and getting technology sort of connected to the current systems that you're working in to help use the Bayesian method. And then another option is the equation-based approach, which is essentially the manual approach, except that you're taking advantage of technology to help you with the calculations. And so specifically looking at and talking about the Bayesian method, just kind of a quick overview. The Bayesian method is a statistical method that utilizes data about how the drug has behaved in prior patients. So you have a lot of data of a patient population where they've received the drug and the levels have been drawn, and you sort of do a population study and you create a probability distribution that shows how the drug normally behaves in a patient population. And then, so that's your Bayesian prior data. And then you get data from your individual patient. And that data could include the patient's weight, their gender, their age, their renal function, as well as the doses they've been given, as well as their levels. So you can put in some patient-specific information, and then the programs do a statistical analysis, and based on the what we know about how the drug has behaved in prior patients and the information you've input about your specific patient, the programs can generate a revised probability distribution, which is your Bayesian posterior information. And then that data can be used to calculate the AUC for a particular patient with low bias and pretty high specificity. So from that, you can create very patient-specific dosing recommendations. There's at least one paper that has been published by Neely, and again, that's from the group out in California. Important to note that they also are one of the groups that has developed a program, a Bayesian program that is available to be used. They did a prospective trial comparing trough-guided dosing versus Bayesian software that included about 250 patients. And they noted that there were fewer levels drawn per patient when they used the Bayesian software. There were lower trough values. They report a trough value of 14 versus 10. There was less variability in the AUC. They were not actually able to demonstrate that the AUC was actually lower, although they did note that in their patient population that received the trough-guided dosing, they were already receiving relatively low doses. But they did show that there was less variability in the AUC. But one important outcome was that they also showed there was less acute kidney injury, and they reported an 8% incidence of acute kidney injury in their patients that were guided by trough values versus 2% in the patients that where they used the Bayesian software to guide their therapy. And they also did not have any treatment failures in the AUC group, although they had few treatment failures overall. This was mostly skin and soft tissue infections for the majority of the patients. So the take home there was that when used clinically, at least for this software program, they did see less acute kidney injury and significantly less acute kidney injury in their patients, and the patients had fewer lab draws and had lower trough values. So the other option for AUC monitoring, if you're not bought into the Bayesian software, is doing the calculations. So the calculations involve using two levels drawn during the same dosing interval. Ideally, you want the patient to be at steady state. You can do the calculations earlier, and there is some data to show that early target attainment does help improve outcomes. So you may want to do it earlier, especially in your patients that are a little bit harder to dose or are more sick. So your overweight patients or your patients that are more critically ill, you might want to do this earlier, but then you may need to double check it again later as they reach steady state. There's different formulas, and I didn't include them in my slides, although if you look at some of the references I've provided, you can find the calculations there. One you'll see referred to a lot is the Sawchuk-Zask method, which is a method that was initially published back in the 1970s and has been somewhat modified since then. The modified trapezoidal rule is another method that you'll see to help calculate the area under the curve for vancomycin, and that modified trapezoidal rule takes into account the alpha distribution phase as well as the beta elimination phase as well. When levels are drawn appropriately, there have been papers, the PI study in 2014, they noted that there was a less than 2% variance when you compare calculating your AUC to the Bayesian methods. It is important, though, that the levels are drawn appropriately. So the timing of everything, knowing when your doses were administered, and getting appropriately drawn peaks are really important to make your calculations correct and improve the accuracy of your calculations. And then sort of what's newer lately is utilizing technology to assist in those calculations. And there's a few different ways that you could do that. In terms of clinical data supporting calculating the AUC, there was there's a few studies out there, but the Finch study in 2017 was the largest study, and this is again from that group up in Detroit. This was a multi-center study of all hospitals within their health system that again included over 1,200 patients. What they found was that using the calculations to calculate the AUC as compared to trough-guided therapy, patients received lower cumulative doses in order to achieve their therapeutic goal. There were lower AUCs, lower trough levels, and the patients receiving the AUC-guided dosing had a 50% decrease in their risk for acute kidney injury. So they reported some significant improvements in treatment. Just to give you an idea, the differences in the AUC that they're talking about, in the first 24 hours, the patients in the trough-guided group had an AUC of about 705 versus 474 in the patients that had their AUC calculated. And over the next 24-hour period, the difference was a little bit smaller, but still significant. The trough-guided group had an AUC of 660 versus an AUC of 532 in the patients that had the AUC-guided therapy. So practical considerations, if you were to consider changing hospital practice from trough-guided therapy to AUC-guided therapy, some things that you'll need to think about are, developing a protocol that would include clearly defining who would be included and excluded from the AUC-guided therapy or the new process. Important to note, meningitis, there's not a lot of data. Most of the papers that I just reviewed were really looking at pneumonia and bloodstream infections. So there were some other infections that we don't have as much data for, meningitis being one of those. So would you want to include those, or would you want to go with the more traditional therapy that we've been using? That would be important to define if you're developing a protocol for your hospital. Important to note that patients that are on renal replacement therapy have generally been excluded from most of these studies, and most people are dosing those still based on trough guided therapy because they don't necessarily reach steady state, and you are, especially in hospitalized patients, they might not be receiving their dialysis at regularly scheduled intervals as they would when they are more stable as an outpatient. Acute kidney injury, if they already have acute kidney injury when you're dosing vancomycin and their renal function may be changing, again, they're not really going to reach steady state if their renal function is fluctuating. So calculating the AUC and using AUC-guided therapy may not be a great choice in patients whose renal function is changing. Skin and soft tissue infections, for those particular patients, especially when you're looking at the more mild and moderate type infections where they're not as critically ill, they tend to be on shorter courses of therapy for your simple skin and soft tissue infections, so you may not need to do quite as much monitoring for them and may be able to stick to more traditional methods. And then, of course, with surgical prophylaxis where you're using single doses most of the time, you know, obviously you wouldn't need to do the monitoring for those patients. The next step after you've sort of reviewed the literature and made choices about who you want to include and exclude, you need to determine how you're going to calculate your AUC. Are you going to explore the option of the Bayesian model, which would involve generally software purchases or online calculators? It tends to be a little bit more of an investment if you're going to use the Bayesian model. Or with the equation-based model, the two-level equation-based model, you could make your own calculation tools, and several of those have been reported in the literature where people have just used Excel and created formulas within Excel and a tool that they could use that they've sort of homegrown. There are some reports in the literature of hospitals that have used EMR-based calculators. So some of the EMRs have tools built into them that you could adapt or modify and use to help you calculate your AUC with tools that you may have available in your EMR or may be able to create in your EMR. There are web-based calculators that are available online, and there's also the option of purchasing software as well for just the equation method. So comparing some of the pros and cons of the different methods if you wanted to make the shift to AUC monitoring, with the Bayesian method, one of the benefits is that there's data out there suggesting that a single level may be adequate for most patients. So that's one of the benefits. With the equation method, you need to draw two levels and they need to be appropriately and accurately timed. But with the Bayesian method, because you have all of the Bayesian prior data, just a single level from your patient is, for more straightforward patients, is generally adequate to give you an accurate dosing recommendation and an accurate estimate of your AUC. So that's one of the benefits, is that the single level with the Bayesian method is an option, and that level can be drawn at any time. Now, as you're making a protocol for your hospital, you might not want to leave that open to interpretation. You might want to sort of develop a policy at your hospital just to prevent confusion, suggesting, you know, at what time you want your level to be drawn. But it is important to note that levels drawn at any time with the Bayesian software can be used to calculate your AUC. Whereas with the equation method, you really need to accurately time peaks and troughs. With the Bayesian method, again, the level can be drawn at any time. You don't need to be at steady state. You tell the software that this is the first dose, and they incorporate that into the calculation. Whereas with the equation method, you're going to get the most accurate estimate of AUC if your patient is at steady state. You may want to do it earlier for challenging patient populations, like I mentioned, for your patients that are more critically ill or your patients that are obese. You might want to do your calculations earlier, but you're going to get the most accurate estimation of your AUC when your levels are drawn when you're at steady state. In general, the Bayesian method tends to be more expensive because for a lot of the programs, you have to purchase them. With the equation method, the cost is variable. You could purchase software. You can use free online software, or you can even make your own tools using Excel or other programs. Some other limitations with the Bayesian method, you do want to understand the patient population that was included in the Bayesian prior data set, so that you know that the patient that you're using the tool for kind of fits the patient population. If your Bayesian prior group did not include obese patients and you have an obese patient that you're dosing, their calculations are not going to be as accurate. So you do want to understand who the Bayesian prior population was. And for most of the software that's available, you can kind of get that information. And that might help you develop policies about who you would actually use that tool in and who would be excluded from that. A limitation with the equation method is that it really just provides a snapshot of what's going on during that dosing interval at that point in time. And if your patient's parameters change, you need to redraw the levels and recalculate. With the Bayesian method, the data can kind of continually be fed into the system. So if your patient's renal function is changing over time and you get new levels, you can put that into the program, and the program can actually, it can retain some of the earlier information that you've entered for the patient. So it kind of becomes this sort of continually changing model that changes and flows over time as your patient changes. Whereas with the equation, you're kind of just taking a snapshot of what's going on at that moment. Another benefit of the Bayesian model is that if you do have some erroneous data that gets entered into the system, maybe the timing was off on one of your levels, and so it doesn't quite fit the curve that you would expect because there was an error in documentation of the timing or an error in documentation somewhere. That's going to have less of an impact if you're using the Bayesian model, whereas with the equation method, if your timing is off and you don't realize that and you input the incorrect time into your equation for a certain level, that's going to have a much bigger impact on your calculations. So those are some, just kind of a comparison of the pros and cons of the different methods. And I'll point out that paper that's referenced at the bottom by Turner and colleagues in 2018 is a good reference that kind of compares some of the programs that are available, as well as some of the two-level pharmacokinetic equations. And they found that, again, given accurately timed levels, that you can produce, the two different methods produce similar estimates of your area under the curve. So I'll give you guys a second to kind of digest all of that and ask you, would you trust Bayesian software results in your patients?
So Erin, this is Kevin. My understanding, and correct me if I'm wrong, is that most of the Bayesian software is proprietary, right? It is you have to pay for it, and they're not going to disclose all the details that go into the modeling because that's their, for lack of a better term, special sauce. Is that correct or not correct? That's just my impression at the moment.
So I'll talk about that a little bit in one of the slides, and one of the papers does kind of address that. Most of it is proprietary. You do have to pay for most of them. There is one that's available free of charge or for donation. The program that was developed by Neely and colleagues that I've mentioned a few times, the group in California, their product is available at no cost, or they request a donation. But in terms of understanding sort of the Bayesian prior group that was included, not all of them disclose that, but some of them do actually disclose who they included as they developed their Bayesian prior data set.
Yeah.
So you may be able to understand the patient characteristics, because that does become important if you're trying to apply this to a broad population.
I mean, from the clinician side, this is one of the big problems that has prevented the use of a lot of risk models for for identifying at-risk populations for early treatment, and many other complicated models of population risk factors, is that at a certain point it becomes so black boxy that it's hard to know if your patient actually is the person you should be using this on. The way that I look at the Bayesian software is it's very similar to when you have a pre-existing drug that's then modified and utilized for a new route, for new diagnosis. You have it is a totally new paradigm for administration of vancomycin. And so just like any of the other drug modifications that we see introduced into the market, it it warrants a significant amount of scrutiny, and that's one of the reasons why why it seems like everybody was interested in it, and why we put together this presentation. And thank you again. This is incredibly helpful, even for people who sort of have some understanding of it already. Um, it's it has an enormous opportunity, but also I think it's hard to know at this point in time how well it's going to work.
Yeah, that's true. And I think if you were to go that route, my guess is that most people would kind of want to start small and be monitoring and evaluating as you go. Pick a sort of a population group that's less at risk, and try it and see how it goes, and probably even possibly double checking with your own calculations to see if what it's recommending is what you would recommend, because it in some ways feels like a blind trust that you have to put in the software to make sure that it's doing what you would want it to do.
Yeah, and that it
feels like
clearly people are polling sort of the same way. Maybe it'll work. Maybe we'll trust it. Maybe not. I guess it. And the checking process, the double checking process, I guess you could call it validation, might be one of those things that you'll have to build into to any kind of rollout.
Yeah.
I will say, all the hospitals in the system that I'm working in right now, we have not implemented this. There's been some discussions, but those exact problems have been part of the discussion, and I don't think anybody's come to a firm conclusion yet.
Yeah. I can see that we're getting close to 11. I don't know, Kevin, do you want me to continue for those that want to stick around? The rest of what I had in this was a little bit of information from groups that have implemented the change to AUC monitoring, not necessarily the Bayesian software, but the change to AUC monitoring, and sort of what their perceptions were and what the antibiotic stewardship group's role was in that. Do you want me to do that, or just sort of leave the slides there that attendees?
I think you should continue. We'll keep the recording going. If people have to drop off, feel free to drop off. Feel free to send any questions through the MASEC email, the moststewardship@worcester.edu email. We'll record the rest of this and then post it on at the DOH website, so that anybody who misses something can catch up on there. I think that would be useful for you to keep going, if that's okay.
Okay. Yep, that works. I will do that. The next slide that I have here was actually a comparison of some of the Bayesian dose optimizing software that's available. This is adapted from that paper that I referenced earlier by Turner in 2018, with a little bit of information from another paper that was published evaluating some of the software in 2012, as well as incorporating some of what I could find online. So there's about 5 that I could find of sort of available Bayesian dose optimizing software. You can see that it comes kind of in different formats. Some of them have to be downloaded and installed on individual devices. Some of them are web-based. There's a cloud-based format that's available. The pricing, you'll see, varies. That second one, Best Dose, they're in the process of changing from a program that is downloaded and installed, which if you go to their website, that is available right now, but they are changing to a web-based format, which they expect to be available soon. That is the one that is free. They do ask for donations, and that is the one that was developed by the group out of California with Dr. Neely. Otherwise, you see the other programs do cost, and some of them significantly. I will note that the DoseMeRx, they have a formula on their website that is based on the number of beds in your hospital, and then as well as the number of models purchased, and they have some basic models and some advanced models. So they have developed software that will help you dose a variety of different drugs. They have aminoglycosides, you know, basically almost any drug that you can think of that we use, you know, very patient-specific dosing based on kinetics, they have a formula for, and you have to buy each formula separately. So like if you wanted the pediatric vancomycin, that's one model, and that's an advanced model that's a little more expensive. If you wanted the critical care vancomycin dosing, that's also an advanced model. Then they have your basic vancomycin dosing for adults, which is one model, and then they have multiple other drugs that you could buy. So the cost that's $12,000 a year that's listed there, it was based on like a 220, I think, bed hospital, and that purchased two dosing models. They purchased an adult vancomycin and a pediatric vancomycin model, and then the cost was $12,000 a year. So that cost would vary based on your size and how many models you wanted to purchase. And the Insight RX, I could not find a price available online, and it wasn't published in either of these papers, but the price that's listed there of $70,000 a year was from another presentation that I saw on one of the pharmacy websites where somebody had done a presentation about this particular topic, and they quoted that price. I'm not sure where it came from, though. So that just gives you an idea of what kind of prices you're talking about. There are differences, and some of them do have integration into the EHR. The ones that are more expensive offer that, and they have an onboarding process where they will come and help you as you try to integrate this into your current systems. Some of them are easier to use. Some of them are more difficult to use. The ones that are easy to use also tend to be the more expensive ones. Some of them offer data analysis programs as part of the program that you're buying. So, you know, if you were going to implement something like this for vancomycin, one of your endpoints would be that hopefully you are decreasing your risk of acute kidney injury. So obviously that is something that you would want to monitor, is how many patients that are receiving vancomycin develop acute kidney injury, and you would want to monitor that over time. And some of these have the functionality to do that for you, where you just print a report, which you know, is really nice, but you pay for that. And I didn't have room in the slide to include it, but some of them do, in the Turner paper, they talk about this. Some of them do provide information about who was included in their Bayesian prior groups, so that you can sort of look at that and determine whether or not that fits your patient population. So just in terms of implementing this, you can imagine that this would be a huge process change for a hospital. So it involves pharmacists, prescribers, nursing. If phlebotomists are involved in your lab draws at your hospital, it would involve them, your laboratory staff. So there would be education for all, and it would really be audience dependent. So your pharmacists are going to be really heavily involved in this. They need to understand the background, the rationale, all the logistics that would happen, and the documentation that would change for them. Prescribers need to understand rationale and how the ordering process might change. Do they order a vancomycin consult? Do they just order vancomycin dosing per pharmacy, or do they have to be more involved in using the software and determining the dose? So that process has to be defined and educated, you know, and as well as what is their role in monitoring. You know, is there a vancomycin service that's going to do this? Is the pharmacy going to do this, or do they have to continue to monitor the pharmacokinetics and make dosage changes themselves? For nursing and phlebotomists, timing is everything, especially if you are not using Bayesian software, but you're using equations. Timing and documentation for drug administration in labs is super, super important. And for laboratory staff, understanding the labeling and reporting, the need for multiple levels. You know, we've gone away from vancomycin peaks based on the guidelines that were published in 2009, but if you're using the two-level pharmacokinetic equations, you're going to need peaks. And so your lab needs to understand that they're going to be seeing multiple levels drawn within the same dosing intervals, and those are not duplicates, but they actually need to be tested and reported, and the timing needs to be accurately documented. And then this is such a big change. People are going to sort of probably want feedback about how it's going, where there are problems. You're going to need to be monitoring the whole process and giving feedback about how it's going, what's going well, where things need to be changed, as well as if all of this effort is actually making a difference in your patient care. So monitoring your vancomycin outcomes, both in terms of efficacy and toxicity, would be important. So in terms of the role of the stewardship program, keeping up with new data and watching for new guidelines. I think up to this point I failed to mention it, but new guidelines are coming. They're under review now. They're expected to be available in the fall of 2019. You know, sometimes not everything follows the anticipated timeline, so we're hoping for the fall of 2019, and that is the target, but watch for those. It will be really interesting to see what they recommend. With all the information in the literature, I think a lot of people are expecting that targeting the AUC to MIC ratio is going to have a bigger role in the new guidelines, but how far they take that in terms of recommendations and whether they still recommend trough monitoring as an option is going to be interesting to see where the guidelines go. So the role of the ASP, you need to watch for the new data, keep up with the new guidelines. If you decide to make the change to AUC monitoring, you're going to need to lead the way, and it's going to be a process change. So you need to educate your stakeholders, get buy-in and support from them, because this is going to be a big undertaking. Getting support from your administrators, you're going to need resources to do this, and they need to come from somewhere. And in most cases, you're going to need IT support, whether that's because you're building your own through Excel or some other program or through your EMR, or whether you're integrating a software program that is purchased or even downloaded for free. You would need to integrate that into your system. So you're going to need IT support. You're going to need money, most likely, especially if you're buying some software, and the time to develop this process and to monitor this process is going to be a pretty significant, significant resource that's needed. You're going to need to make choices about your monitoring tools and programs. Are you going to do something homegrown? Are you going to, buy something commercial? Are you going to use something free that's online? How are you going to integrate that both into the workflow and into your documentation systems? And what resources do you need for that? You're going to need to develop protocols and policies. Looking at the tools you're choosing, who's included and who's excluded is going to be important, as well as process issues such as how are the orders placed, is there a consult service, is it dosing by pharmacy, and the medication and labs, all of that piece. How are the orders for medications and labs placed, as well as the timing, making sure everybody understands what the processes are and the policies are for that. Education is huge. It's always huge, but this is such a sweeping change and affects so many departments that there will need to be a lot of education. And then monitoring the process change and giving feedback to your users is going to be important. So it's a big, big project, and I think the stewardship folks, whoever's involved in stewardship at your hospital, are going to need to be involved in leading the way on a program like this.
I would also
the
say,
last thing I wanted,
oops.
yeah.
This is Kevin. I would also say you're going to need more than one champion. So you can be the champion for your, in pharmacy or as the stewardship champion, but it's going to need multiple people really driving towards the goal. I would say at least one physician champion, and probably both a physician and maybe one of the hospital administrators. Because as I said, as Erin said, this is a multifactorial process change, and it's really going to be a complex implementation. You're going to have representation from the lab to just make sure that even the data getting into it is correct. So, yeah.
Yeah, 100%. Physician buy-in is is huge. And so if you're at a hospital where your stewardship pharmacist or your stewardship program is generally a pharmacy-run program, you're going to need physician support and physician buy-in. And you're probably going to need at least one physician to be kind of the mouthpiece for you to get other physicians to buy in and support this as well, because this is not going to be something that can just be, you know, the pharmacy department says we need to do this, and so everybody does it. You're going to need a lot of support and a lot of buy-in. So you kind of have to think about who your key team is and who your stakeholders are, and get them on board and get their support and come up with a plan with them. There's a really interesting paper if you're thinking about making the change to AUC-guided dosing. There's a really interesting paper that was published by Clays and colleagues out of Baltimore, where they are a large academic hospital there, and they made the change to pharmacists to dose AUC-guided strategy. And they have published sort of their experience as well as the pharmacist perception, which I found really interesting, and I think a lot of our audience is probably pharmacists, so you'll probably find this interesting as well. They did a pre and post implementation survey evaluating the pharmacist perception of the program. There's a lot of really interesting data that's published there, and an interesting discussion. One of the things I thought was most interesting was the concerns about time commitment remained high, which is not surprising. We're not recommending this change, or nobody would undertake this change expecting that this is going to improve efficiency and, you know, make things move faster and, you know, make things take less time. And what they reported was that the median time to calculate a single dose changed from 8 minutes prior to their change to 15 minutes for a single dose of vancomycin. So if you're going into this thinking this is going to improve efficiency within your pharmacy workflow for vancomycin dosing, that's probably not the case. The target is really, you know, clinical outcomes and patient safety, and it's something that would have to be incorporated into the pharmacist workflow. And they did have concerns about it, and those concerns remain high even after implementation. However, despite that, there was an overall positive perception of the program among the pharmacists that were participating in this program and responded to the survey. So more pharmacists agreed that the new practice was improving patient safety. And this last slide here I thought was really neat, was they did a word cloud of one-word impressions from the pharmacists that were participating in the policy change to the AUC-guided therapy. And overall, you see mostly positive words there. There are a few, you know, some people felt it was overwhelming, people were nervous, you know, people thought it was maybe a little controversial still, a little confusing, but you see a lot of interesting, it was overdue, it's good, it's exciting, it's really useful, you know, it's ambitious, it's fantastic, it's helpful, they felt it improved safety, they were making a difference. So even though it sort of made the pharmacist workflow a little bit more challenging, they felt like overall it was a good thing and that they were making a difference for their patients, which I thought was good to see. So just kind of to summarize, I think the data is moving towards AUC-guided therapy. The real issue is how are we going to calculate the AUC? And we do need more data for special populations, our obese patients, and, you know, and other special populations. We are going to need more data. The cost implications are going to be important. You know, the cost of implementing the change, as well as if there are any cost benefits. If we are really reducing the incidence of acute kidney injury, we know that that's a costly adverse event. So I suspect that we'll be seeing data published in the years to come about the overall cost effect of making a change. We're also probably going to need data on organisms other than Staph aureus. There's not a lot out there in terms of AUC-guided therapy for other organisms, as well as more data about the clinical outcomes, especially with the Bayesian software programs. Watch for the new guidelines. They're expected to be out in the next few months. If you're going to make the change, you really need to think through the process and all the practical implications, and explore the options that are available. There are a lot of options available for calculation assistance, even if you don't want to go the route of the Bayesian software. There's calculators available online, and you can, make your own. So exploring what options are available for your AUC calculations. And as leaders in antibiotic stewardship, we should all be prepared to work with our stakeholders and our prescribers to determine what's best for our hospital. And the last thing, I think we've still got some audience members here, so just open it up if anybody has any questions. And maybe in the interest of time, if you have questions, raise your hand, and I'll kind of go through to the next slide just because we've kind of gone over time here. I did include a more complete reference list here, so if you want to pull any of those papers that were referenced in the presentation, the data is available there, the information is available there. And I want to make sure to ask that everybody go to our Poll Everywhere site and give us some feedback about the conference. Tell us what was good, what was bad, what you'd like to hear about in the future, and let us know what you think. And thank you very, very much for attending and participating today.
Thanks, Erin. I'll leave this open for just a bit, and then people can continue to fill out the conference feedback form even after the webinar shuts down. And yes, just because we ran over time, any questions, please send to our mostewardship@worcester.edu email. Thanks everybody for participating, or for being on today's webinar. This is a complex topic, and of course there are no clear solutions or easy solutions for this as of yet. It's going to be very interesting to see what happens when the guidelines come out, because if it does really push towards it, this is something that maybe hospitals will really need to think about a lot more very soon. So you guys can all reference Erin's webinar then. Great. Thanks, everybody.
Thank you.